Good afternoon, everyone. Welcome to the Geriatric ED Collaborative bi-monthly webinar. My name's Don Milady. I'm an emergency physician in Toronto, Canada, and I'm your host for this afternoon's webinar. As you can tell, we've got people dashing in at the last minute, still in the middle of supper in some places, and we're very happy to have them. Just as everybody is filing into the room, just let you know that we've got a great panel for you today, all of them focused clearly on frailty. All of us who work with older adults are aware that the topic of frailty has come more to the forefront of everybody's mind in the last while, let us say. I know for myself, I can remember 20 years ago, thereabouts, when I asked somebody about frailty, the answer, and this was a knowledgeable person, was, yeah, nobody really knows what it is, nobody knows what it means, and nobody knows how to measure it. So that was rather disheartening in 2004. I think we've come a long way since then. It's now, well, just wait till you hear Dr. Conroy's final comment, and it really is a word and a concept that's at the front of everybody's mind. In fact, many people think that frailty may be the concept that is sort of the grand unified theory of older person care, the thing that starts to pull everything together and make sense, and that moves our thinking forward about how to provide care, how to make changes in care that people will be receiving everywhere, particularly in the emergency department. And I guess it's clear that a lot of people share that view, because I noticed there's currently 110 people on the line. We've had nearly 300 registrants for this webinar, which is the largest number we've had since 3 years ago, when that little virus came along and we were wondering what impact it was going to have on older people. We're incredibly lucky to have these three distinguished guests with us today. Two of them are international leaders in the study of frailty and its practice in the emergency department. And the third is one of our GEDC core faculty, who is a frontline nurse clinician who brings a perspective of how to implement frailty screening across a whole system. We'll look at several different options for screening for frailty and why it matters, and what happens after you identify the patient's level of frailty. Next slide, please. We asked you in advance, when you registered, this question: how does frailty change the ED management of older patients? And we got 300 answers back. Next slide, please. I just grouped them into a few kind of illustrative or general comments. It was very interesting, and I think would probably be the basis of a valuable paper in itself. These are some of the things that you see. We're currently working on processes to identify it early, even at triage. It starts moving care forward on the acute floor, even though this is in the emergency department. Wondering about what happens after the emergency department and what impact does frailty have on that. Observations that people stay longer, suffer more when they have frailty. The next one's a positive one. At that site, it seems that they do identify frailty, and it leads to patients being brought to a room more quickly. I just included the last one at the bottom left there as a sober touch of reality, that somebody somewhere out there feels that frailty has an impact minimally at present. And so I hope that we'll be able to change that perspective through this webinar. Next slide, please. So this, I hope many of you are familiar with the Geriatric Emergency Department. We are a network of community and academic emergency departments. We work together to define best practices in the care of older people in emergency departments, to educate clinicians about those best practices, to disseminate and help implement them, and to study them. Next slide, please. If you share this vision, you can join us. We'll text into the chat box the link to our website. You can follow us on Twitter at the GEDC. And next slide, please. Our work is very generously supported by two important philanthropic agencies, the John A. Hartford Foundation and West Health Institute, without whose help we wouldn't be able to do this work, and we're deeply grateful to them. Next slide, please. This webinar on frailty in the geriatric ED is being recorded. It will arrive on our website in a few days' time. Access to our website is free and open. So if you find some value in today's presentation, be sure to pass it on to your colleagues and friends, and they will be able to access it after the fact. While you're there on our webinars on demand, you might want to select any one of our previous 25 webinars, which cover everything from what matters most to telemedicine, interdisciplinary care, how to implement a geriatric nurse specialist program, financial case for implementing geriatric change, delirium screening, you name it, and we've probably covered it over the last 3 years. Next slide, please. Just before we get started, and I introduce this panel, since we are coming from many places across the United States, across North America, and around the world, I'd ask you to put into the chat box where you're calling in from and what your role is there. It really helps us and our panelists know who the audience is and how we can better serve you. I'd like to introduce our panel for today. First is Dr. Kenneth Rockwood. He's a geriatrician at Dalhousie University in Halifax, Nova Scotia, Canada. There, he is the director of the Frailty and Elder Care Network for Nova Scotia. He's spent most of his clinical work, though, over the last many years, working in an emergency department at Queen Elizabeth II Hospital in Halifax. So he knows what geriatric care on the front line of the emergency department looks like. And he spent most of his very productive research time over the past 30 years focusing specifically on the topic of frailty. He's best known for developing the concept of the Frailty Index and the tool that we're going to be talking about a lot today, the Clinical Frailty Scale. Dr. Simon Conroy is also a geriatrician. He practices in London, England, though he is calling in today from holiday on France, so special thanks to Simon. He has spent most of his clinical work, though a geriatrician, working in the acute frailty unit of the emergency department in Leicester, England. His academic time has been focused on standardized frailty screening using the CFS in over 120 emergency departments across the National Health Service in the UK. Along with our friend, Dr. Jay Banerjee, he's the editor of the extremely helpful The Silver Book, which is a guide to the first 48 hours of the care of injured and ill older people. If you're not familiar with it, which will be posted into the chat shortly, I think you will find it extremely valuable. So that's enough of me talking. I'm sorry to have taken up so much of your time. I'd like to start with Ken, first of all, to give us a bit of an introduction to his understanding of frailty. So Ken, we can end the slideshow at this point. Connor, thanks. How does, you've spent a lot of your time working with frailty over the decades. For many of us, though, many of the people on the line, it may be a relatively new concept. So for the beginner, what is it that we need to know?
Thanks, Don. I think the first thing we need to know is that frailty is intrinsically bound up with aging. And in some sense, people who are frail are in some ways aging faster than their chronological age peers. So what does that mean? So every minute that goes by, we accumulate at some subcellular level some damage, and the damage can go unremoved or unrepaired, and if enough of that accumulates, it turns into a deficit, and these health deficits can then accumulate with time. And remarkably, for populations over the life course, sort of the median estimate of how much we accumulate clinically detectable deficits, so the subcellular and molecular damage that has gone unremoved or unrepaired and manifested itself, it's around 4.5% per year. And those of you who are financially astute will know straight away that that means that the doubling time for frailty is every 15 years, because it's just like compound interest. And aging, for technical reasons, we can think of starting only at age 15. So just like compound interest, a thing we used to say, remember those days, but we're back into it again now. So just like compound interest is not the first doubling time that's important. You're 15 years old, you got almost nothing wrong. If you're 30, you still got almost nothing wrong. It's the last one. And in Canada, for most people, the last doubling time they experience is between the ages of 75 and 90. Now, there's another doubling time after that between 90 and 105, and there's rounding error after that. But for the longest time, that 90 to 105 has been less important. You're seeing visibly it's starting to become important right now. And it will become more important as time goes by, because Canada and the US are amongst the countries that experienced the baby boom. And in 2021, the leading edge of the baby boom began to turn 75. And 75 is the beginning of the last doubling time. And not by coincidence, it's also the time at which most of the diseases of old age become manifest. It's when you see a sharp increase in hip fracture. It's when you see a sharp increase in the number of people who are diagnosed with dementia. It's when you see a sharp increase in the number of new discharges from hospital with congestive heart failure, or the increase in recurrent admissions within the year with COPD. So people who are frail exhibit the hallmark feature of any of these illnesses, which is to say that the illnesses of old age come as a package, or the dogs of old age hunt in packs. And so that's where the challenge arises from our standpoint, is the complexity of people who've got more than one thing wrong, and very likely have a lot of this compounded by the social vulnerability that they experience, because those are the people who are more likely to express many diseases all at once. So it's this kind of perfect storm of multiple interacting medical and social problems, now growing exponentially. And if the pandemic has taught us anything, please God, it's the understanding that exponential processes don't care how we feel about them, whether it seems fair, whether we think we're prepared, whether they're kind of busy now and such. They just relentlessly push forward. And so that's why I think frailty is now becoming a matter of some urgency, particularly at the pointy end of care, like in the emergency department.
So once we accept that frailty is a serious thing that we need to be able to recognize, how do we go about recognizing it?
Well, that comes to the second major point I want to get across, and that is there are degrees of frailty. And so from my standpoint, it's really, really important that we don't just distinguish frail and not frail, or even robust, pre-frail, and frail. Once people become frail, there are grades of frailty. And the reason we need to know about that is because that will have a very important influence on their care needs. And so the way that we recognize frailty is we need to think about the ways that whole body system failure presents itself in old age. So one way is really easy, coma and shock and all this sort of stuff. Okay, that's a bit extreme. What about other things? So as humans, we've evolved to have upright bipedal ambulation, opposable thumbs, divided attention, and social engagement. So they integrate a lot of information if we can do those things. They also integrate a lot of information if we can't. So the person who falls is more likely to be frail than the person who's not. And again, the circumstance will help us understand that. Why, this 82-year-old man fell while crossing the finish line at the half marathon. Okay, probably not a frailty presentation. But this person fell from a standing height and fractured their hip, probably will be a frailty presentation. So what we've done with this thing called the clinical frailty scale is looked at the ways in which all of these various features come together and the typical order in which they unfold. So for example, very mild frailty, one of the complaints with that is the person is moving a bit more slowly. So they've still got the upright bipedal ambulation. It's just not working as well. They're less socially engaged. They're no longer quite as independent as were. They don't formally meet the criteria for dependence, but the things that they need some help with are high order features. Like I'm speaking to you from Nova Scotia, where we had 6 inches of snow in the last 2 days. And so when you get that amount of snow that quickly, that's what it is on average. Some places have accumulated a lot. And so there are some structures where people need to get the snow off their roof. So when you're young and fit and whatnot, it's all a lark, getting the snow off the roof. But when you're older, it becomes a real challenge. So they need help with these very high order functions. So that person would have very mild frailty. They're not dependent, but they're at risk. They're not falling down, but they move slowly. And they're not socially disengaged, but their circle of people with whom they interact has gotten smaller. So they would meet, and often they complain of feeling tired. So they would meet the physical frailty definition with the 5 famous things that give rise to it. And you still call them frail, but they're very mildly frail. The very severely frail person is the person spending most of their time in bed. And a lot of the time they're spending in bed, they're spending asleep. You might say, well, that sounds like they're dying. And in fact, they are. The typical life experience for the very severely frail person who's a grade 8 on the clinical frailty scale versus the grade 3 of the clinical, grade 4 of the clinical frailty scale, the very mildly frail person, they are in fact within 6 months or so of dying. And so, but they're all frail. So as we get to grips with frailty, we understand there's degrees.
Can I break in for a moment? Because I think our audience would benefit from seeing visually, I think, what you're talking about. So
yes,
can you, audience members, in the chat, you'll see links to the clinical frailty scale. And Connor, could you pull it up on screen so Ken could speak to it as he has already described it?
Thanks, Don. So if you are able to see it right now, you'll see that it comes on a card, or it can come in an EMR. This is the 2 sides of the card that we use. It's available for free, by the way. We ask if you're going to use it at the level of your institution to sign something promising that you won't turn around and sell it. But one of the interesting things I've found out in my time.
Send some of the money to Ken.
No, don't sell it. Make it available for free. Because I'm Canadian now, we're weird like that. So we've got these little icons, and I expect there'll be a new version coming soon, which will change these icons subtly. But you can see that icon number 1 is someone who is running. Now he's running. You can tell even at this very small icon that's there that he's not running with, he's not going to get the 4-minute mile or some such, but he's out running. And so that's good. That makes him very fit. And then we see grades of very fit, managing well. And interestingly, in virtually every case series to date, it's uncommon to see reports where very fit and fit are reported on at all. They're normally merged into this idea of managing well. And the person who's managing well, their medical problems are well controlled. They're maybe occasionally symptomatic. They're able to walk around and get around. They're independent. But the thing about them is they don't exercise. And speaking as someone who's not a natural athlete, but who nevertheless manages to exercise most days, the fact that it works as well as it does is the only reason I would be out doing it, because I'm not the sort who would engage in this spontaneously. So that's the managing well. Then level 4, very mild frailty. And I think the thing we're going to do next time is take the cane away. Lots of people with very mild frailty don't have a cane, and probably just put it in the hand of the person with the walker who's got mild frailty. Many people with mild frailty have a walker, but most don't. But you can see that the mobility integrates so much information that we just represent it, the degree of frailty, more or less by the extent to which mobility was going on. They started to sneak in towards the end. dependence in other people for function. So the way you track it at a distance is mobility. You can grade it by fine amounts based on the level of function they have. There's a parallel set of staging that conforms very much to mild, moderate, severe dementia for cognitive impairment. And we look at some other things as well. So at parts of the scale, we're taking exercise into account. We're also taking the degree of comorbidity into account. But from a screening standpoint, we've kept it to be as simple as possible, which is focused on a few things. When the clinical frailty scale was first developed, it was brought together for the pragmatic reason we had a large epidemiological survey in Canada, and we had thousands of people who'd had clinical exams. The exams were done to make sure that the guts of a comprehensive geriatric assessment was there. And then we had to have some way to summarize, well, what about them? You know, how do we make all of this understandable? And so the CFS came about as a way to grade the degree of frailty, because we did have the word, but we didn't have the operationalization of the stages to the same way. And we worked this through and validated, and that's where it came from. So it started off to summarize a CGA, and now it screens for it.
Ken, I'm going to bring you to a halt for a moment, because I do want to hear from Simon, who has taken this, and to allow him to give some explanation of how it can be used in practice. Because I don't know, I'd be interested to know in the chat box how many people are actually familiar with or using clinical frailty scale in their own emergency department practice. Anyhow, over to you, Simon. You've had a lot of experience in the United Kingdom with implementing the clinical frailty scale. What was that like, and what impact on care has it had over a whole very large system?
Yeah, thanks, John. Thanks, Ken. I must have listened to Ken.
The slide, Connor.
I must have listened to Ken talk about the concept of frailty and the CFS many tens, if not hundreds of times, and I'm still enthralled by the simple elegance of the concept. I know there's a lot of complexity behind it and a lot of hard work that's gone into it, but my biggest regret is that I hadn't met Ken a few years before we started something called the Acute Frailty Network, which is probably where we've really started to look at frailty, or at least risk stratification in the acute context at scale. So a bit of history. I used to work, as you alluded to already, Don, in a place called Leicester, which is a very modest middle England town or city. But I met a very wonderful person there called Jay Banerjee, who many of you will know. He's an emergency physician with an interest in frailty. And we both shared a passion for improving outcomes for older people, having done some work that demonstrated generally very poor outcomes in this population following attendance at acute care. And the question was, how do we get things better? And any of you that have been involved in service developments will know that a key to improving outcomes for any particular group of patients is to first identify the population you're intending to benefit from your care and support. Cut a long story short, Jay and I worked together on various service developments in Leicester for a few years, and then the opportunity came to work with a team at NHS Elect, which is part of the National Health Service in England, which is an improvement collaborative on something which later came to be called the Acute Frailty Network. So the role of the Acute Frailty Network was to fix the NHS. Yeah, so the problem, in quotes, for the NHS is older people living with frailty, or at least we didn't have the language then, but that's the perception. And all these people that really shouldn't be in hospital because, you know, they're all old and they're close to the end of life and they really shouldn't be clogging up our hospital wards, which sounds terrible, but actually it was a comment or a phrase that was not uncommon at the time, back in 2015 when we first started this work. So there was an inherent problem with the design of acute care systems, which was that they were ageist, which is not a huge surprise because healthcare systems are a reflection of society, and society, at least the society I live in, remains fundamentally ageist in the way that it goes around its day-to-day business. The work that Ken and colleagues have done on frailty is the antithesis to ageism. It's the ability to recognise the heterogeneity of the population, to name, degrade, degree of frailty, and allow us to adapt our care accordingly. So back to the Acute Frailty Network. The mission was to improve outcomes for older people. We used large-scale collaborative, which ultimately involved over 120 sites around England, some in Wales, a few in Ireland. I see some of our Irish colleagues are here tonight, so welcome to them. And we use quality improvement methodology to try and implement the evidence base for improving outcomes for older people. Year one was wasted. We spent most of the year trying to work out how to identify the population at risk, and every site, there were 10 sites in the first cohort, started using their own version of how to risk stratify. You know, some used ISAR, some used frailty scores, some used Freed, some used Edmonton. Lots and lots of different approaches to identifying frailty. And we probably learned one very important lesson was just stick with one. Sorry, Ken, anyone will do, but just pick one, because you need to be, you have some simple rules to help you navigate through complexity. It just so happened that the best one available on the market in terms of its elegance, its empirical evidence base, and its relative simplicity, which you know, when you're implementing in an emergency department context is very, very important, was the clinical frailty scale. And over the last 10 years or so, we have worked with many sites up and down the country to support them in identifying population at risk using the frailty scale to stratify that population. And we do it rather crudely into mild, moderate, severe frailty, but it nevertheless starts to recognize the heterogeneity of this population. And we encourage teams, emergency departments, acute teams, geriatricians, and frailty teams more generally to adapt the care that they are providing to the stage that the person is on their life trajectory. We have made some progress, and I think the language of frailty is becoming much more current, and it certainly appears in the policy context and is relatively well understood on the ground. We still have a long way to go in terms of improving our overall offer to this population. But we're starting to slowly get the message through that not all older people are the same, that there are people at one end of the spectrum and there are people at another end of the spectrum, and the care that we provide and the outcomes that we anticipate for them will correspondingly not be the same. So it's been an amazing journey, and Ken's been very supportive, and indeed many colleagues on this call have been very supportive, and we're proud of the work we've done, but boy, have we still got a way to go.
So Simon, can you give your audience, who are mostly emergency department adjacent, either working in an emergency department or are responsible for one or interested in them, what has been your observation at your own site or across the system as to how implementing the clinical frailty scale or any tool for identifying frailty, how does it make a difference in the practice and in the care provided?
So I've now got to the stage where I do not understand how I could treat somebody unless I understand where they are on their life trajectory. And I use the concept of frailty because that's the one that I think works best. Other tools are available. And it's very simple. You know, Ken's already touched upon this. Those people who have frailty scores of 7 or higher, which is severe frailty, at least in our data, have a 50% one-year survival following an emergency presentation from whatever reason, for whatever reason. Whereas people at the other end of the spectrum, so severe mild frailty or even those that are more robust, who have the same age, some similar comorbidities, will have a single-digit mortality at 1 year. These are fundamentally different people for whom their mortality outcome is completely different. And I don't know how anybody can treat these people in the same way. And the problem that we've encountered, and you know, with respect to my ED colleagues who do a fantastic job managing an undifferentiated population day in, day out, the protocolized approach that tends to be applied to this population just does not work. You cannot protocol your way out of frailty and complexity. You have to recognize where someone is. You have to recognize what matters to them, what it is that you're trying to achieve, and adapt your care accordingly. So going back to my own context, standard protocols would be older persons fallen over, bang their head, they're on an anticoagulant for their atrial fibrillation. They must have a CT scan of their head. They must have a conversation with a neurosurgeon who mostly won't do anything very much about it, but that's a by the by. And everybody follows these rules. So all patients get everything for every condition that they present with. But there's an alternative approach to this. Yeah, if we recognise actually that this patient who is presenting at triage, I'm talking about doing frailty scores the minute the patient arrives in hospital. Our standard in the UK, or at least in England, used to be 15 minutes, it's now 30 minutes. We have a few problems at the moment, is that we should be assessing their degree of frailty at the point of triage and arrival in the emerge, so that it informs our clinical decision making. So instead of sticking people on a standard protocolized pathway, we will now say, okay, where is this person on their life course? What is it that we're trying to achieve? What matters to them? And is the answer to that question a CT scan? And 9 times out of 10 for people with severe frailty, either through consultation with them or their loved ones or next of kin or representatives, is actually they're not that bothered about having lots of scans and lots of tests and waiting around in a busy, crowded emerge where they're exposed to all sorts of noise and other noxious stimulants. They'd rather be at home in a place of comfort and dignity where they can do what matters to them. And so Jay and I would spend our ED shifts sitting in triage, assessing frailty and finding alternative dispositions for this group of patients, allowing them to achieve more of what matters to them.
So certainly addressing the what matters most issue for the patient. Also, it sounds like probably having a rather big impact on the way the emergency department functions by expediting the care that people need and want. So so just practically, is this identifying for your undifferentiated older patient coming into the emergency department, do you think, aside from when you're on duty or Jay is on duty, aside from those situations, do you think your average emergency physician and nurse is impacted by the knowledge of what this person's frailty is?
So that's a big question, Don, as you well know. I guess to try and structure the response. So you can think about it, the 3 different levels of systems, so micro, meso, macro. So at the micro level, so the individual patient level, we've already illustrated how frailty can impact upon clinical decision making and treatment. And then there's the interaction with our clinical colleagues through the process of education, training, leadership, role modeling, etc., that helps them to understand how a concept of frailty can or could or should even influence their clinical practice. At the meso level, so I'm talking now about service structures, so lots of systems up and down the country, not just Leicester, but across England and other parts of the UK, are encouraged through policy to routinely measure and act upon frailty scores. So we have systems or services that are now emergency services that are required to report upon frailty scoring in the 65+ population. Of course, ticking a box and actually acting upon it in a meaningful way are 2 completely different things. But that's where I go back to my first point about the importance of education and training. So simply having a policy or a service level requirement to measure frailty does not engender the change that we want to see on the ground. And at the macro level, the kind of country level, we've been fortunate enough to be able to influence national policy such that it filters down from on top. And I guess it's a combination of all 3 of those things. So you want a policy context that supports the idea of measuring frailty and recognise its importance. You want people on the ground that understand the concept and can apply it in clinical practice and use it to improve the care that they offer. And you want measurement at the service level to try and reduce the variation that inevitably exists. That is really difficult to achieve. I don't know if we achieve that in emergency medicine for hip fracture, for PTA, for angioplasty, for any condition. But for me, those are the kind of approaches to try and standardize care.
Good, thanks a lot. So I'm going to move on. Thanks for that, Simon. Aaron, we're going to move on to Aaron. So older people are sort of uniform around the world, but the systems that provide care for them are not. So we're going to move to a different country, the United States of America. Aaron, you've led a lot of different projects moving towards geriatric ED practices across a fairly large system. And you chose a different approach to this topic of frailty could you tell us about how Advocate Aurora is functioning and how identifying frailty makes a difference in your pathways?
Yeah, thank you, Don. Yeah, so when we really started our Geriatric ED program planning late 2014 and actually implemented in 2015, we chose the ISAR, Identification of Seniors at Risk, Dr. McCusker's wonderful generalized risk score. To be 100% truthful or clear, we didn't really intentionally implement that as a frailty score. But as we continue to learn, and how Simon was talking about that difficulty of translating what we want into actual practice and having it consistent and effective, some of the things that we really are keen more and more on are the first two questions. And if Connor, if you're able to put up the ISAR slides, what you'll see with the first two questions, one is talking about before this illness that brought him to the ED, have you need help on a regular basis? And then the second one is, have you needed more help in the last 24 hours? These are excellent, or I shouldn't say excellent, let's say adequate proxies for some of the concepts that Dr. Rockwood and Dr. Conroy were talking about. So this is really kind of a proxy approach for us to be able to at least begin to engage with these concepts. And some of this, and this is really to Simon's point, is this has two benefits. One is we invested lots of time with the ISAR, to build that existing foundation. And, there's lots of many hard fought victories to try to get it implemented and effectively used, because as we all know, a score is just a score. How do you translate that into actual practice? And then one of the other pieces, since this is foundational, this ISAR is kind of the foundation where we build all our different protocols on, is that we are able to integrate some of those points of what we've learned of, one, what some of the issues are, and then also their support structures. Do they need help? Do you have help? These are important points along when you're making points for making decisions at disposition. And kind of on reflection, when thinking about this, I know that you mentioned this in the beginning. It seems very similar to how we deal with delirium. We all kind of know about it and we've all experienced it, but do we have effective ways of identifying, assessing, intervening, both in the ED and then post ED as well? But this is very exciting to, one, affect, starting to hear with Dr. Rockwood's CFS, and then learning from Dr. Conroy how to begin to implement this so we can affect change, and very excited to continue to learn with that.
Aaron, can you just give us an example of how, like practically, how the ISAR is used and what kinds of things does it trigger? I'm thinking about the first Advocate place, Aurora place I visited in Sheboygan, where the ISAR was an imperfect but a good tool for triggering all kinds of things. Can you tell us about some of your pathways?
Yeah, so one of the big points is our nurses do perform this ISAR for all older adults. We use 65 and older. It can be done at triage, but more we focus this more when the patient is actually in the bay with their assigned nurse. And with those questions, we really been stressing the point of critical thinking for our nurses. One is to ask the questions, that's one, but what are you using with that information? Have they needed more help? What was the help that they need for? Who are those support people in your life? With this, we have this as part of our flow working with the provider groups, the physicians, the nurse practitioners, the PAs of, oh, with Mrs. Jones, we've, be able to express X. And also talking with our case management team to be able to identify, oh, where are appropriate post-ED services. Along with that, this really ties into additional what we call like protocols with our mobility protocol and our falls protocol. And so not only are we identifying some of these risks, some of these what their help or what their needs are and what their support is, but then this is when we bring in additional team members. We're able to do the timed up and go, and we use this as a trigger to bring in our physical therapy. It can be as much as doing a physical therapy consultation in the ED, where they can help us with the providers with assessing and giving recommendations, doing such things as home safety evals when taking in these concepts of frailty. This is very helpful for being able to make appropriate planning for disposition, but then also additional resources. Is it outpatient physical therapy? Is it home care? Is it a community education class? There's many things along the way, and you could easily anticipate, if we had additional disciplines with pharmacy and other disciplines. So it really does take a whole team, and that's how we're trying to do this, is really, if we're at least engaging in some of these concepts, we'll admit it's not perfect, but starting to engage with this and working with our stakeholders to meet those needs, both in the ED and beyond.
Thanks, Aaron. Yeah, so at our site where we introduced ISAR about 12, 13 years ago, and there was a period now receding when it was quite uniformly done. Another unexpected good outcome was that just the practice of asking those questions made our clinicians, doctors and nurses, start noticing that these topics were important, like how much help this person needs on a regular basis and how much help they've needed recently, and whether they've needed hospitalization or have problems with their memory. And I noticed that over time that attitude sort of got inculcated into people's, doctors and nurses, assessment of and thinking of about older people. So thanks, Aaron. I'm going to go back to you, Ken, and we'll leave the slides that we can just go out of the slide deck completely. Ken, I don't want to turn this into a cage match between great Canadian geriatricians. And I do know that our our North American, particularly American colleagues, mostly use ISAR at the moment. What Aaron was just describing there, of using it as a sort of proxy for frailty, how successful do you think that to be?
So I think it's quite reasonable. It sure beats not getting into these really important issues, right? And so however it's done, this is the key bit. The concern I have, to be frank, is about the degree of frailty. And my concern as a general proposition is that frailty becomes the polite form of ageism. And I think we run into that if we say, oh, well, he's frail. Yeah, we'd like to, but he's frail, right? And the way that I try and resolve this is to talk to people about goals of care. So at the hospital where I work, people come in, it's a standard thing, and you will actually hear poor young residents, not the students anymore than allowed, but the young residents going off to get the DNR, right, on the goals of care, to get the DNR. And I say to people, from a geriatrician standpoint, the goals of care are, can you handle the mechanics of toileting well enough to wipe yourself? Because if you can't, that's commonly fixable. And it makes a huge difference in terms of the care that you're asking other people to provide. When you come to the need for intimate personal care, this is a well-known risk factor, but it's actually very poorly documented in the literature, and people don't know how to engage in that conversation. And starting talking about memory is a really good thing, but very commonly with the people in whom big differences can be made, big differences can be made with small things. And that's the bit that I would want to see how, to what extent do those conversations get encouraged?
So that actually was going to be my next question, is how can frailty be used to make a difference in the kind of care that's being provided? So that's like just a very clear, basic example. Including in goals of care conversations and what matters most, if you were setting up the ideal emergency department, Ken, what would you suggest? How can a knowledge and a screening for frailty be added into the ideal geriatric emergency department?
So I would think that it's reasonable to have the screening at baseline, at triage. I think it's really important, though, that we help to address this thorny problem where there is unsuspected variability, and that is informative. And the problem is this: people come to the hospital and they more or less have this expectation that they'll be fixed in some way, that, they're bad enough to go to the hospital, they expect to be fixed in some way. And for most people, they're realistic. They're not thinking about what they're like when they're 20, but they are thinking about what they're like when they were last kind of stable before things went bad. And it's a tough discipline, but it looks like it's very hard to make someone better than they were 2 weeks before they got sick. So that's why at the clinical frailty scale, we really try to understand what they're like 2 weeks ago. And most people that's a comprehensible period of time that they or their care provider can do that. And so if you've taught people that with this CFS or however it works, the things that are important are the things that make us human, right? The social engagement and the opposable thumbs and being able to move about and such. Those things, that's a short checklist. And people are able to get some sense. And then what saves them at that point is the pattern, right? So if we know you're bedfast, we know a whole bunch of things. So I encourage people to ask about the mobility and elaborate that a little bit with the life space. And that allows you to understand what is a plausible goal of care for this person, not do you want strangers to jump up and down you if you die? It's what you need to get home. But it also then allows you a way to engage with the care partner, because the care partners are variable too, and some of them are perfectly happy to take them back if they were like what they were 2 weeks ago. But others, they were barely hanging on 2 weeks ago, and they get it a whole lot better. And that will change the entire conversation around who's going to have to do what the length of stay will be, and so on and so on. So that's what I would encourage, is that we imagine there will be patterns-based conversations that will allow us to know what needs to be done next.
So you allude to a question that also came up in the chat. I know that you always emphasize the importance of scoring a person's frailty based on what they were like well before the current acute illness. But there's a question from Ting Poon in the chat about what about temporary situations where the person is going through acute treatment for cancer, for example? How does that impact frailty?
Yeah, so that's a great question, and I don't have a definitive answer on it. I do reflect, though, in my time running the medicine consult service in the emergency department, when we were talking to the cancer folks, they were very, very, very strict about, the Konofsky performance scale and the 2 weeks criterion there, and what they're like right now. And you might say, well, yeah, I know they're bedfast right now, but like 3 weeks ago, they're running around. They're like, I don't care, right? The protocols are based on the evidence of where they are just now. And trajectories. So in cancer, I get it that, there's no going back. There is some flexibility with respect to the trajectories. This is not yet knowable, I don't think, at the level of the individual. We can say, though, for a group, as a group of people, that the people who define themselves as having been bedfast 2 weeks ago for whatever set of reasons will not do as well as the people who were out walking around 2 weeks ago for whatever set. So we can't ignore it. And how we work out the individualized care plan winds up being very important, that we do have some footnote we can place against that. And then the other thing is I'm very, very keen that we not make falsely dichotomous decisions in the emergency department, as we were talking about. It's like going to do everything or do nothing. No, we're going to do the thing that's appropriate. And then we're going to guide ourselves in the next 48 hours. Right? Everyone knows the golden hour of trauma. Very few people know the golden 48 hours of recovery.
Simon, I see you got your hand up, and I did have a question for you, but you jump in as you wish.
Thanks, Don. It was the point really just to develop a bit further with Ken on cancer and indeed other conditions. As Ken knows, we've worked within specialised services in England, including cancer and including other conditions such as complex spinal surgery, where one of the key questions that kept recurring was, is the frailty due to condition X, Y, or Z, or is it something else? And how valid is the construct within a specific population? We're still working on this, and yeah, we don't have clear answers. But the answer I tend to give my colleagues is that you need to differentiate between multifactorial frailty, remembering, of course, as the CFS and the frailty index approach is about the accumulation of deficits. So if people have got multifactorial frailty due to a combination of cerebrovascular disease, dementia, sarcopenia, polypharmacy, comorbidities, etc., then the frailty score is probably a valid reflection of where they are. Whereas if they have what we term unifactorial frailty, so they're otherwise pretty good, but they've got a horrible cancer or they've got a terrible spinal stenosis that needs surgery, then maybe it's not applicable in terms of the prognosis and the way that we use frailty in multifactorial frailty or accumulation of deficits. And I'd be interested, Ken and I haven't really had a chance to discuss this, but I'd be interested to see what his thinking is on that point, whether that's a reasonable way to navigate through this complex territory.
Yeah, so I agree.
Before you answer that question, I'm just going to cue our audience. We have about 10 minutes left on this webinar. You have access to several experts in frailty. If you have specific questions or general questions that you want us to get to, please pop them into the chat right now, and we will try to get them. Otherwise, Ken, go ahead.
Yeah, so single system frailty is better approached as disability, the illness with the disability. That would be the shorthand version I would have. And certainly, as you know, Simon, we saw this dramatically with the pandemic and the NICE guideline and such.
Simon, it's a bit odd that an academic clinician would say, it doesn't really matter what tool you use, just do something. And I fully agree with you. What do you think what impels you to feel confident to say that?
So it does matter, and I've already praised the approach that Ken and others have developed, and he'll get no more praise from me tonight. But for me, there's a bigger issue here, which is about culture change, service change, influencing hearts, minds, the way people think. Whether Aaron's using the ISAR or Ken's using the CFS or someone else is using the Freed, all I particularly care about is whether or not they're adapting their approach to older people. If they can use an evidence-based approach to that, so much the better. But are they adapting their treatment, their care, their attitudes, their approach to the needs of this older person based on where they are on their life trajectory, and how they rationalize that and come to arrive at that position, for me is less important than the actions that follow. So I'm much more interested in culture change and engendering different approaches tailored to the needs of the individual than which specific tool you use. I mean, of course, the answer is CFS, but other tools are available.
Thanks. So on that note, I noticed one of the questions from, I believe, somebody in Iceland. Can anyone use the CFS? Does a clinician need special training? Ken, what do you say? Or either of you? Sorry.
You go ahead, Simon.
So we've probably got a fair degree of experience of trying to generalize the use of the frailty scale, and the short answer is yes. Anybody can use it with training and with support. We've had healthcare assistants, nurses, therapists, doctors, not quite receptionists yet, but I will leave that space for Ken to populate because he's got more sophisticated methods for allowing other non-clinical professionals to use the CFS.
So we have used it across a very wide range of healthcare providers. And most healthcare providers can. And those who can't, it's not a function of the training, it's a function of their understanding of A, precision, and B, whether they're happy to make a judgment. Because we set the CFS up to be judgment-based. You're trying to integrate a lot of information and come to your best determination. And, good judgment, as Mark Twain said, good judgment comes from experience, which comes from bad judgment. So it takes a certain humility to, or presumably it does, take certain humility to make your judgment and bring it into a place and say it out loud. And I know in any training session that we've done, there will be at least someone for whom this whole idea is abhorrent. And they're looking for an objective measure and such. And they're looking for exact intervals between the scales. But that's the wrong way to go about. That's empirically, demonstrably the wrong way to go about it. But some people have the felt need and they dress it up with words like they're being objective. But so that's the thing to be aware of. If you got some folks who can't do it, don't have them do that. There's lots of people around who can get it done. There's other things they'll do exceptionally well. So, try and work with the team and make sure that on the team, you've got the right people doing the right job.
So in the waning moments of this webinar, which clearly could have gone on for several hours, Eula, I'm just going to turn it over to you. Have you called any questions from the chat that you want to relay?
I think maybe if we can just do one final one is the questions with regards to any good scores that can be used by telephone triage. That's always challenging. We can't see the patient, but curious to know.
Simon's hand's up.
So slightly a bit of a cheat answer. So my most recent experience, and I know Ken's done some work on this as well, is working with ambulance service in London, where we are supporting ambulance clinicians with their clinical decision making relating to older people living with frailty. The ambulance crew have had education and training on frailty, so this is why it's a bit of a mealy mouthed answer. But our consultations are phone-based. Occasionally we switch to video, and I'm able to triangulate the information that they're giving me with my assessment of frailty. So that's one example, and actually a very powerful way of helping identify what we're trying to achieve with this particular group. So I think so. I have no empirical evidence. Maybe others have got views on that.
I don't have more empirical evidence, but we're starting a project with fire departments now. Mm-hmm. And because an important thing an important call for fire departments is falls assist. And so how do we get them to look into the precipitants of fall that may identify people to a frailty service? And so I think this is going to be a really interesting approach in the fire service. And confession, a million years ago I was a firefighter, but in the fire service, one of the most prized skills is triage. Up there they call it size up, and the size up has a particular way to report and a few things that give a lot of information, and they're good when they're present. It's harder when they're not. But what we're looking at right now is what's the firefighting equivalent of the size up of a frail older adult, and what are the things that would be the moral equivalent of smoke in the soffits, for example. So
great. So real quick, I just want to say some takeaway points there is just telehealth and paramedic use, even for frailty. I want to just add, Don, this was probably one of our most international sessions. We had over 14 countries represented. I'm going to read them all out just because I think it's so cool. England, France, Germany, Iceland, Ireland, Malaysia. So we had Asia represented too, Norway, Spain, Switzerland, Sweden, Turkey, Wales, Canada, both coasts, US, both coasts. We had VA and Indian Health Services representation and a wide range of specialties and disciplines. So just over 150 people, attendees, not including the panelists. So very, very, very good.
Connor, if you can get us back into the slides just as I'm wrapping up. So yes, I really need to say a huge thanks to our three specialists, Ken, Simon, and Aaron. It's rare that you get this kind of opportunity to hear from the horse's mouth in this case. Horses' mouths. We have prepared some takeaway points next slide, for each of the 3 presenters. And those, of course, will be available on the website in a few days for access. Good. And next slide. So this is the special treat which we held for the end of the webinar. The GEDC has launched, many of you may be familiar with geriem.com, which is a e-learning resource that I created a number of years ago. We've completely upgraded it, updated it, revised it, improved it, and added an important module, which is specifically on frailty in the older ED patient. And since many of your questions were around training, I think you'll find a lot of resources on that. The link is there, or you could just search GEDC online learning, GEDC frailty. It's all there for you. Next slide. Next slide. We've compiled all the resources that were mentioned here today, which will be available on the website. Next slide. And we will be having another webinar. We just haven't decided what we're going to talk about yet on March 23rd. So please put that on your calendar. Next slide. If you're interested in learning more, that's a book that we have created about written about creating a geriatric emergency department. Next slide. More resources. That's us. And the most important hearty thank you to the people who make all of this possible, the John A. Hartford Foundation and West Health Institute. And a final huge thanks to Drs. Conroy, Rockwood, and Mr. Malsch. It's been a great topic and presentation. I think we'll have to revisit this topic again in the near future.